Coming up next on Being Well, neurosurgeon Emilio Nardone stops by to talk to us about minimally invasive spinal surgeries for those who suffer from disc herniations and spinal stenosis. We've got a lot of great information just ahead, so don't go away. Well, I'm so happy that Dr. Emilio Nardone, did I say that right?
Correct.
Neurosurgeon has come by Being Well today. First, we should explain your practice is Central Illinois Neurohealth Sciences, and you're located in Bloomington, Illinois, correct?
That's correct. Yeah, we've been in Bloomington for over 13 years right now, and of December last year approximately, we started having clinic at Sarah Bush because of a need for neurosurgical services here, and that's been quite well.
Okay, so you're a neurosurgeon. For people who aren't real sure what that is, why don't you tell us about what are the kind of things that you treat in your practice?
From the word, you can say that we treat brain and spine. Typically surgery of the brain and spine, and quite often we also do peripheral nerves like carpal tunnel, ulnar nerve release. The large majority as a number is a spine surgery. Approximately 20% is brain, mostly tumors, vascular malformation of the brain, and so forth. But
okay.
The large majority is spine as a number of cases.
So when does a patient typically come to see you? At what point in their prognosis, or would they come see a specialist such like a neurosurgeon?
Yeah, typically they are referred by primary care physician or other specialties, or we have a good number of patients that come directly as a self-referrals. If you have a brain tumors or any problem, some strokes of the brain, we see them readily. Of course, if you have a spine problem like a disc herniation in the cervical spine, in the lumbar spine, stenosis, or many conditions that usually degenerated related to degeneration of the spine, and we see them upon referrals. And it's a quite variety of cases that we see and that we do, including, as I said before, compression of nerves like carpal tunnel, ulnar nerve. And the most common cases are disc herniations.
Okay, so tell us specifically what kinds of things you're doing at your practice at Sarah Bush in Charleston, Mattoon.
Being on my primary place where I operate, so we don't do complex cases here, but the large majority are spine, minimal invasive microdiscectomy, meaning surgery for disc herniation in the neck and in the back, lumbar stenosis, and some fusions, 1 or 2 level fusion are getting done here. We cannot keep the patient more than 2 days here. That's why the more complex cases usually are done in Bloomington.
Okay, so let's talk about one of your specialties is minimally invasive surgery for disc herniation and stenosis. Can you kind of talk about how that's different from the more traditional surgeries for those ailments?
Yeah, well, over the years, we have seen an improvement into the approach to spine surgeries by minimizing the soft tissue trauma that the surgery itself creates in order to achieve the goal of relieving the patient's pains. Over the last years, it is clear that minimal invasive surgery, what we call keyhole approach to spine, where an incision is less than 1 inch in your back or in your neck, we are able to achieve those goals. And the most important factor is the patient satisfaction. There's much less pain after surgery, and they can return to work much easier, and they can be done on an outpatient basis.
So what, when you talk about, we have a picture that shows what the scarring is like after. How did that, you've got these 2 holes basically. Prior to that, how big was the incision?
Well, it varied. The typical open incision sometimes can be even several inches. And several inches incision in the back, it means devitalizing and opening several inches of muscle in your back. And that's why some of the spasm and pain post-op comes from. So by minimizing that approach, you see why patients do much better with much less pain and much less use of pain medication on post-op.
So is it kind of like arthroscopic surgery, like what they do on knees and stuff like that?
It's not arthroscopic because the spine or brain, they don't have a real cavity in there. It's just a minimally access surgery where the opening is very small. Some people place tubes. I use a small blade to access it. And once the opening is performed, then we place a microscope. And under microscopic guidance, we perform the surgery to remove the disc herniation or to relieve the narrowing called stenosis.
Okay, let's talk about disc herniation, and I'm going to grab the model of the spine. I want you to explain to our viewers really what happens when you herniate a disc, and I've had it before. Why does it hurt so much?
Yeah, well, This is a plastic model of the spine. This is the anterior portion, and this is the back portion of the spine. And what do we see that is grayish looking is the disc that allows the spine to move. And like any structures in the body, it can break. And due to wear and tear of the disc or a sudden accident or an accident, the disc breaks. And then this is the back part of the disc. When it breaks, it protrudes out and impinges the nerve that passes by into the spinal canal. And that's why not only they have back pain, but also they have a lot of leg pain. Because that nerve goes to form the sciatic nerve that goes into the leg.
Okay, and what is this disc stuff made out of? Is it cartilage or what is it?
Yeah, it's made of a fibrous ring of cartilaginous material and an inner core called nucleus pulposus, from a Latin word that means it's the shock absorber, the center of the disc.
So is the term herniated disc, bulging disc, slip disc, are those all the same things or are they different?
It's kind of semantic.
Okay.
Bulging means just barely bulging out.
Okay.
It means that the disc membrane has lost elasticity and protrudes out. Herniation means it's actually broken and a small fragment from inside comes out and impinges the nerve.
Okay, so is it actually, I'm going to turn this around one more time. So is it actually this whole thing that comes out? Or?
No, actually there's a small breakage in the backside here where the membrane breaks and a small fragment typically comes out.
Okay.
Because it's a very narrow space, even a small fragment can cause a lot of damage.
Okay.
And the patient not only have pain, they can have a neurological deficit. They can have a weakness in the foot or in the leg, numbness, tingling, and so forth.
So I know a couple of my friends have herniated discs, but they haven't needed surgery. When do you know as a neurosurgeon when someone needs surgery to correct the problem?
Fortunately, the large majority of disc herniation cures themselves without an aggressive approach, without surgery.
Okay.
It is known that discs sometimes can reabsorb, can shrink away from the nerve and the symptoms get better. When do we need to have surgery? The main indication is persistent, severe pain that does not improve with conservative treatment, and presence of progressive neurological deficit, foot weakness, numbness, signs of spinal cord compression, and so forth.
So why is it that, it's weird when you herniate a disc, your back doesn't really hurt. It's your leg and your hip and sometimes your foot. That's just all the nerves that connect to those areas are in your back? Is that why it hurts so much?
Actually, the first symptoms of disc herniation is back pain or neck pain, depends what it is. Because the rupture of the disc causes the irritation of the nerve fibers around the annulus, the membrane of the disc that causes the back pain. But then after a few days, the back pain subsides and leaves you with the leg pain due to the impingement of the nerve that disc herniation has created or has caused.
Okay, so what long-term can happen other than being in constant pain if you don't have that surgery? Can you suffer from permanent nerve damage if you don't get that herniation taken care of?
Definitely. It depends where the herniation is and what nerve is affected. It can leave you with a foot drop. It can leave you even with paralysis if it's in thoracic or lumbar spine.
Okay.
So sometimes if it's a central disc herniation, it can even leave you with probably bowel and bladder and sex.
Okay. Are there certain vertebrae or discs that are more susceptible to herniating than other in the spine? Are there certain ones that herniate more often than others?
The two segments that moves the most is the cervical spine and the lumbar spine, for obvious reason. The thoracic spine has a little movement because of the presence of the rib cage. And so the cervical and lumbar areas are more prone to rupture. And in the cervical and lumbar area, the one that moves the most, respectively, the C4, 5, C6, 7, and C6 and C4, 5, C5, 6, C6, 7 disc tend to rupture in the cervical spine, and the L4, 5 and L5S1, the bottom two discs in the lumbar spine, are more prone to rupture.
So basically the top and the bottom, and not so much the middle.
That's the bottom line, yes.
So when you have patients come in, what's kind of some common causes of a herniation that you hear? What's the story, or is there one thing that kind of seems to resurface?
Actually, it could be multiple. It's daily activity that causes it. Even a sudden movement, lifting up a bag, lifting up a luggage. But as I said, there's never a common specific injury that happens across the border. It can be any movement that causes it. Because sometimes there's a wear and tear that goes through the years, and then all of a sudden, even a little sudden movement can cause a rupture.
So if you have the disc herniates and does it mean that you have less disc material then? Or can it regrow itself or regenerate itself?
Well, there's a small piece that comes out,
Yeah.
but the piece is small. There's a lot of a disc still left, and there's a lot of movement at that segment. The disc does not regenerate, and that's why the symptoms may persist because of the degeneration, but we are not at the level of a technology where we can regenerate disc.
Okay. So let's talk about another ailment that people suffer from, and that's spinal stenosis. First of all, explain what it is and what are some of the symptoms.
Stenosis means narrowing. There is nothing else than narrowing of the canal where the nerve comes through.
Okay.
It's mostly common in the lumbar spine, but it's also possible in the cervical spine. What causes it is aging. Typical spinal stenosis is common in elderly population above 60 years of age, and it's due to a combination of degenerative processes that involve the facets, the joints of the spine, that get thicker. In medical terms called hypertrophic, means thicker facets. And also the ligaments that is on the back of the spine called ligamentum flavum or yellow ligament, it gets thicker with time and with aging, so the combination of these processes cause remarkable narrowing on the spine.
Okay. So what does that feel like if you have stenosis?
So it presents with back pain, but most important with what we call, the big word, neurogenic claudication. What does it mean? The people, when they feel good when they lay down or when they sit, but when they stand up and start walking, they get symptoms in the legs of pain, tingling, numbness, weakness in the legs. And quite often they have a fixed amount they can walk. They say, I can walk only half block and then block. And then I get all the symptoms. I have to bend over to relieve some of the symptoms, and I have to sit down. I sit for 5-10 minutes, and then I can walk again. That's what we call neurogenic claudication.
Okay, and so when you say the spinal column, that's actually inside of here, right?
Yeah, that's right.
Okay.
So what do we see yellow inside are all the nerves.
Okay.
Now, being this a spine plastic model, we don't show the ligaments. So this bone gets thicker, these are the facet, and then there's a ligament in between there, the yellow ligament I mentioned before, that gets thicker and causes the narrowing around the yellow nerves in the back.
Okay.
So what do we do in these cases?
Yeah, let's talk about the surgery for that.
When they fail conservative treatment or the symptoms are quite advanced and the stenosis is remarkable, with a small incision, approximately 1-inch incision in the back, we are able to get down to the level, once we localize it with x-rays, where the stenosis is, and we make a key incision right there into the bone, where there's a window with a drill and some other instruments, remove the bone and the ligament that's causing the tightness of the canal.
Okay, so what's the recovery time for someone who has the minimally invasive version of stenosis surgery?
It depends how many levels you have to relieve the stenosis, but people with one level, they stay in the hospital one night and they go home next day, and within a few weeks they should be back to normal and then should be completely relieved immediately from the pain. They'll be able to ambulate the same day and go on walking on their own feet the next day.
That sounds like a nice alternative to...
And actually, what I want to mention also, there's a special technique that I wouldn't say I developed, but I refined in doing the minimally invasive decompression. The large majority of decompression in the lumbar area is done through a typical midline approach where the whole bone in the backside of the vertebra and the ligaments is removed. And we modify the technique with an oblique approach. Small incision, and instead of going from the posterior portion, we go from the side and making the key incision and the hole into the vertebra from the side approach and reaching not only the same side, but also the opposite side. Okay. So we are able to completely decompress the spine, but at the same time, avoiding the injury of all important ligaments that form the structure of the spine and are important for stability.
So while you have that, let's explain how you do the surgery if someone has disc herniation. How does that one work?
Again, we make an incision on the skin, more superficial. We get down to the level that is localized on x-rays. And you see, this is called lamina, part of the vertebra, with a little drill and carry some punches. There's a special instrument. We bite off the bone and we access the canal where the disc is herniated. And the disc is herniated underneath the nerve. So the nerve gets moved gently and we retrieve the fragment from underneath the nerve. We make sure there's no bleeding, and then we close off the little incision with a couple of sutures.
Now, is this a method that a majority of neurosurgeons are doing, or is this something that's fairly new that just, your practice is doing? Or is this kind of the trend of treating back surgeries or for performing back surgeries?
The importance of minimal invasive surgery is spreading, and has been spreading over the last years. So more and more neurosurgeon and spine surgeon adopt it. I think the large majority are still doing traditional surgery. It all depends from your training and attitude, but there's more and more of the new generation that gets converted into the minimal invasive approaches. They have a little bit steeper curvature to learn them, but once you learn them and adopt them as a technique, they're quite rewarding.
So did this surgery evolve because of technology of instruments and things like that, or just surgeons like you developing just a new technique? I mean, what made it possible to be able to do surgeries in this way?
It's a combination of factors. Definitely a better understanding of the anatomy and physiology of the spine and how patients respond, also guided by patient satisfaction. That becomes a more and more of an important factor in overall healthcare, as well as advancing in the technology allow, including visualization, microscope and light sources that have progressed through time, have allowed us to improve into this technique.
Now, you had mentioned that you do some fusions. Do you do that here at Sarah Bush or not?
Yes, we do.
Okay, so fusion always sounds like, someone says, oh, I have to have my disc. That sounds not, it doesn't, it sounds like a last resort. Is it
It should be.
It should be. Okay, let's explain what is that when you fuse the discs together?
Well, what are the indications for fusion, first of all? If you have a slippage, called in medical terms spondylolisthesis, it means that the disc is failing. Instead of the bone lined up, the bone slipping.
Okay.
So that can create a lot of back pain and eventually can pinch the nerve if there's a lot of slippage. That's an indication to fuse it.
Okay.
We cannot give a new spine. We cannot reproduce the stability of the spine. So the segment that is failing, it needs to be stabilized with screws, rods, and eventually the nerves need to be decompressed. Another indication for fusion, severe degenerative disc disease can create a lot of pain from a mechanical point of view, a chemical point of view. And if those patients have failed to improve with the conservative management, indication for fusion or artificial disc is there.
Okay. So what's the recovery time for something like a fusion? Is it longer than the disc herniation surgery or some of the other surgeries?
It's definitely more of an invasive approach, and it is a longer one. We can do minimal invasive one-level fusions with small incision, one on each side, but despite that, the fusion is definitely more than a microdiscectomy for disc herniation. And depends how many levels is done, but typically the hospital stay is 1 or 2 days, still, so a relatively short hospital stay. It requires 6 weeks to be completely fully recovered, although people are able to ambulate well. And then it's a progressive approach through the next few months, how to lift weights and how to twist. We want to make sure that the fusion takes. So it takes several months before restrictions are lifted.
Okay, so let's talk about some of those restrictions. If people have, you can set that guy down if you want to. If people have that surgery, do they have to spend the rest of their life being, I don't want to ruin my surgery, or do you recommend that you need to be active? Are there things that people should avoid if they've had these types of surgeries, or can you go back to a fairly
definitely.
active life?
The approach to mobilization after surgery for spine is completely changed. When I was in training 20 years ago, many people were mobilized in bed, staying in bed for a long time. The approach is completely different. Mobilization, movement is the key for recovery. And of course, the minimal invasive approach helps the patient be mobilized because they have less pain. Actually, we get them up right away, as soon as they're awake from surgery and they're able to walk. Because many of the surgeries I mentioned to you before, they're done on an outpatient basis. So people go home and able to handle routine activities right away.
So have you seen in the time you've been a neurosurgeon that back surgeries and back pain is increasing? Seems like everybody has back pain.
Well, there's more conscience of that.
Okay.
Before, many, many years ago, people were supposed to live with the pain.
Yeah, they just live with it.
Yeah, now people want to have high quality of life in everything that we do. And of course, technology have improved, the understanding of the basic process have improved, and that's what has led to the remarkable change in the spine care.
Okay, so if someone has dealing with some back pain issues, how do they know well, maybe this is something more than just, a little bit of pain. Maybe it is a little more severe. I should see my doctor, which may lead to seeing a neurosurgeon. How do you know if your pain is a little more than just, some people tolerate pain better than others, but how do you know it's something a little more severe that should be looked at?
Well, as a general information, almost 100% of human beings during their life suffer a major episodes of back pain. So it's quite common. So your question is quite pertinent. Okay, one is we need to seek more attention. Well, if the back pain is associated to what we call radicular pain, I mean pain that goes into the arm or into the leg. If it's associated with tingling, numbness, sensational weakness, any other changes in neurological status, that prompts immediate evaluation. Or if it's just pain, if it's rather persistent, if it's weeks or months that it's been going on and it's not improving, then needs to be looked into it.
So I'll ask you back, doctor, if say you go out and you landscape your whole yard and, it's a lot of work and your back hurts, something like that, typically how long should that take to kind of recover from that? From just sort of back strain, and then
typically within 2 weeks the situation should be remarkably improved.
Okay, so that was kind of my question. Is there a certain time period if pain persists beyond about the 2-week mark, then
that's right. Sometimes it can last longer, but as long as there's a trend in improvement over the next few weeks, that's satisfactory to have a conservative approach.
Okay, I always like to ask this question, not that we want to put you out of business or anything in the back surgery department, but are there things that we should be doing to take care of our backs to make sure that we are healthier and aren't suffering from back pain?
I think the two most important things that we can do is being as thin as possible, so fight obesity,
yes,
and eat well, properly, and exercise. Exercise to have a good core muscle strength. If we do that, we do what we can to avoid back issues. They're going to come anyway. They're going to be present anyway.
Yeah.
But at least that's what we can do to improve it.
Okay, and if you're not seeing improvement, you see someone like a qualified neurosurgeon who can hopefully get you back on the road to health.
We'd be glad to do so.
All right.
Yeah.
Thank you so much for coming by Being Well. We hope to have you back again.
You're welcome. My pleasure.
Thank you.
A man named Kevin Liu was a triathlete who developed a rare disease that caused his heart to fail. In a matter of months, he went from intense competition to barely being able to walk. He needed a heart transplant. In addition to a new heart, he got a whole lot more.
Well, Maureen likes to run, that's how we met.
Running and competing in triathlons are passions for Kevin Liu. But when a disease called giant cell myocarditis caused his heart to fail,
Couldn't believe how weak I was.
everything stopped.
I pretty much got dizzy and just passed out.
The cause of giant cell myocarditis is unknown. It results in the immune system attacking the heart.
He presented with a disease where his body attacked his own heart and destroyed it, and destroyed his heart function to the point that it was negligible. But because he was in such phenomenal shape, he could still do things that he should not have been able to do.
But eventually, Mayo Clinic cardiologist Dr. Ferris Timmy says Kevin's heart deteriorated to the point where he needed a heart transplant.
I think if Kevin had not been in the shape he was in, he would have died.
A heart was not available immediately. Doctors implanted what's called a ventricular assist device, a mechanical pump, that kept Kevin's heart going.
We didn't actually know to think this would ever end.
They waited and waited. And while they waited, Kevin and Maureen made a wonderful decision to set a date for their wedding.
The date was determined by when the best man and our family could be there.
Hey, how are you doing? Good to see you again.
Even Dr. Timmy attended, but the most exciting moment came the day after their vows.
We were downloading the photos from the cameras. And it was when they called and they just said, "Are you in town?" And I said, "Yeah." And they said, "Well, we have a match." I'm like, "Oh, okay."
Wow.
I'll be there.
What a wedding gift. The gift of life.
48 more years, right? We have to be married 48 more years so we can celebrate our golden anniversary.
And now that Kevin's fully recovered, he and Maureen can share their passion for running and love for each other.
Well, I've done 4 half marathons already this year in a triathlon, so I'm doing much better.
I think his story is a testimony to both his intrinsic reserve and the power of love. I really do.
For Medical Edge, I'm Vivian Williams.
There's nothing like the feeling of taking a dip in cool water on a hot summer's day. But if you have arthritis, exercising in warm water can help relieve pain. Holly Furfer has more in today's Health Minute.
3 times a week for the past 2.5 years, Paula Mason could be found here at this Arthritis Foundation aquatic program.
When I don't come to the class, I can tell I don't have nearly as much range of movement and endurance.
Paula is one of millions of Americans with arthritis. It affects people of all ages. The disease damages joints in the body, making movement sometimes painful and sometimes even impossible. That's where the warm water exercise program comes in.
Arthritis Aquatic Therapy is a joint range of motion and flexibility class designed to help people with arthritis enhance their quality of life and to have less associated pain.
A therapy pool offers participants several benefits.
It allows their bodies to warm up to the movement. It allows for greater blood flow, warmer muscles, warmer joints, for greater fluid and range of motion. The water allows for resistance to their movements, which will provide them a level of strength from the activity.
And they can exercise without fear of falling and injuring themselves. To Paula, the class has been life-changing.
I'm a lot happier because I'm able to exercise my whole body.
For today's Health Minute, I'm Holly Furfer.